Hope you're all doing good. Wish you all a happy new year. I actually wanted to conclude this discussion part on December 31st, 2018 itself, but so many comments, so many addition of new keywords. In fact, the description part of the video was not sufficient to update information out there. We have a character limit of 5,000 approximately. So that's the reason why I'm trying to make a new video, so that I'm sure even if I add up one topic to the discussion part, it will be of enormous help to all of you, right? So we'll start with myoepithelial cells. So there was a question on myoepithelial cells and their location, I reckon. In fact, myoepithelial cells, they have a diverse location. So they're present in exocrine glands. Myoepithelial cells, as you can see in the image, they are located beneath the basement membrane of terminal portion of most exocrine glands, including salivary, lacrimal, mammary, and sweat glands. They have variable distribution among the glands and species, and are also occasionally within the same gland during the development. In salivary glands, they are typically arranged to form arcs around the acini and orient along the long axis of the ducts. In major salivary glands, myoepithelial cells are seen in relation to acini, intercalated ducts, and striated ducts. Whereas in minor salivary glands, they are present or they are invested in the acini with processes continuing on to intercalated ducts, right? So the excretory ducts and rather rudimentary striated ducts are devoid of myoepithelial cells, which is another important point, right? So they have diverse location, which is very, very important, and depending upon the type of glands, major or minor, you can see variable distribution of myoepithelial cells. Now moving on to the next topic, it's not Microsoft MS, but it's Streptococcus mutans, as you know. So Streptococcus mutans is present in predentate period or at the time of eruption. I think there was a question of that sort. So literature clearly suggests that Streptococcus mutans does need a solid tooth dentate surface in order to populate, right? We'll go through the literature. The notion that dental caries in animals is an infectious transmissible disease was first demonstrated by Keyes way back in 1960. Since that time, a group of phenotypically similar bacteria, collectively known as mutant streptococci, has been implicated as a principal bacterial component responsible for dental caries in humans, as you all know. Infants do not harbor this organism until sometime after the teeth emerge. Mutant streptococci require presence of a hard, non-desquamating surface for their colonization. Now moving on to the next topic. Muscarinic agonists. So different chemicals which have agonistic activity against muscarinic receptors, in specific M3. So if you refer literature, even in Tripathi, it's clearly given that acetylcholine, pilocarpine, carbachol, bithonicol, they are non-selective muscarinic agonists which are active at M3. However, cevimeline hydrochloride, I guess that was one of the options. Cevimeline is a cholinergic agent with muscarinic agonist activity, prominently affecting M1 and M3 receptors, right? So this is some information related to muscarinic agonists, right? Now moving on to the next topic. Is antibiotic prophylaxis required in patients who have orthopedic implants? So we'll go through recommendations and then we'll come to a conclusion. The American Academy of Orthopedic Surgeons and American Dental Association, so they have given some evidence-based clinical practice guidelines in regard to this antibiotic prophylaxis. So the first recommendation is graded as limited, according to which this recommendation proposes that the practitioner consider changing the long-standing practice of routinely prescribing prophylactic antibiotics for patients with orthopedic implants who undergo dental procedures, which means not required. Antibiotic prophylaxis is not required. And the second recommendation, which is graded as inconclusive, addresses the use of oral topical antimicrobials in the prevention of periprosthetic joint infections. And the third recommendation, a consensus statement, addresses the maintenance of good oral hygiene. So these are some of the recommendations given in relation to the antibiotic prophylaxis in orthopedic implant patients. So the first recommendation proposes that the practitioner consider changing the long-standing practice of routinely prescribing antibiotics for prophylaxis purpose, right? I hope it's clear. Now moving on to the next topic. Iodine pump, iodine trap. So which of the following is stimulates iodine pump or iodine trap? So thyroid stimulating hormone, if you refer literature, thyroid stimulating hormone stimulates the synthesis of thyroglobulin, the iodine trap, the coupling reactions in the follicular cells, and the release of iodothyronins into circulation. So this iodine trap is nothing but a pump in the follicles that actively pumps iodine from blood into follicles, right? Now moving on to the next topic. So when do you leave a canal open? I got one or two keywords pertaining to options. Weeping canal or swelling. See, first of all, when you find that the canal is weeping, or whenever there is any drainage of pus or any fluid from the canal, we leave the canal open, but not indefinitely, not even for 24 hours. Previously it was like leave the canal open for 24 hours, make the patient come again and then close the dressing. No, that's no longer practiced because of chances of reinfection from the saliva. So what we do is, in case of drainage from the canal, we leave the canal open, make the patient wait in the OP for some time, and then once the drainage is complete, we again reevaluate the canal, and then before we send the patient, we place a medicament obviously, and then we close the canal before we send the patient, right? So this is some information pertaining to leaving the canal open. If in case you have more appropriate question or including all the options, do let me know in the comment section. We'll see if we can have a better answer, right? First of all, we need to have a better question to get a better answer, isn't it? Now, moving on to the next topic, abrasion. How does it heal? Primary, secondary, epithelialization. So it's very simple. I'll go through literature, you'll understand the fact. Epithelialization. So wounds with loss of epidermis or partial thickness skin loss of dermis heal by epithelialization or regeneration. Examples: abrasions, skin tears, stage 2 pressure ulcers, blisters, and partial thickness burns, right? Now, the next topic, antifungal agents, which are the first line prescribed in case of oral candidiasis or thrush. So it's oral fluconazole. So in Tripartite it's clearly mentioned that oral fluconazole 150 milligrams per day for 2 weeks is highly effective in candidal infections, especially candidal infections of mouth, but should be given only to patients not responding to topical treatment. So if at all there is any topical antifungal agent mentioned in the options, do let me know. We'll go through this question once again, right? So oral fluconazole 150 milligrams per day for 2 weeks, right? A single 150 milligram oral dose can cure vaginal candidiasis, just an add-on point. Now penultimate topic, PNAM. So which of the following related to PNAM is false, isn't it? I think that was the kind of question you got. See, cleft lip and palate. So PNAM is something which is done pre-surgical in order to minimize the adverse effects, or rather the side effects of surgery. So it has numerous benefits which we will go through in literature now. Pre-surgical nasoalveolar molding technique developed by Grayson is a new approach to pre-surgical infant orthopedics, which reduces, or the objective is to reduce the severity of initial cleft alveolar and nasal deformity, enabling the surgeon and the patient to enjoy the benefits associated with repair of cleft deformity that is minimal in severity. So the primary aim of PNAM, pre-surgical nasoalveolar molding, is reduction in soft tissue and cartilaginous cleft deformity to facilitate surgical soft tissue repair in optimal conditions under minimum tension and in order to minimize scar formation as such. It allows stimulation and redirection of growth for controlled predictable repositioning of alveolar segments and gives the ideal arch form, normalizes the tongue position, aids in speech development, improves appearance, gives a psychological or psychosocial boost, and finally improves feeding as well as bone contour. So these are in specific the advantages of pre-surgical nasoalveolar molding. So the objectives of PSNM, right? a PNAM, pre-surgical nasoalveolar molding. Objectives include to provide symmetry to severely deformed nasal cartilages, to achieve projection of flattened nasal tip, to provide non-surgical elongation of columella, to improve the alignment of alveolar ridges and reduce the distance between cleft lip segments. So this is in brief some information pertaining to PNAM, advantages, objectives, and what's it all about. Now moving on to the final topic. A question on topical fluoride. So I got few keywords like non-cavitated lesions or cavitated lesions. How are they best treated by? So I'm not sure of the question as such, but what I understood is that caries, topical fluorides, how would you use them and which would be more effective? So let me know if at all there is any additional keyword pertaining to this question. So in one of the references, it's clearly mentioned that with fluoride treatment, a non-cavitated lesion can be remineralized with fluoropatite and have greater resistance to subsequent demineralization than hydroxyapatite, as we all know. Even very low concentrations of fluorides are effective as anti-caries agent. Commonly used fluorides in oral care products include sodium fluoride, sodium monofluorophosphate, and stannous fluoride. All of these provide important fluoride ions and which inhibit demineralization and promote remineralization. In addition, stannous fluoride is considered to have unique properties as it provides efficacy against bacterial acids in addition to its fluoridating benefits. Along with that, in textbook Shoba Tandon, it's clearly mentioned that when you compare sodium fluoride topical agents with APF is 50% more effective than sodium fluoride comparatively. And stannous fluoride, it's clearly mentioned that highly insoluble tin fluorophosphate complex forms on enamel surface that is more resistant to decay than enamel, right? So let me know again if in case I missed any keywords pertaining to this question, and also if you have any additional options, do let me know. We'll check this question once again, right? So these are some of the additional topics which I wanted to highlight in this specific video. I'm not sure if it is final video or not. If at all I get more questions and more options, definitely I'll consider making another part as well. So I hope it's clear. I wish you all the best, love you all, and once again, Happy New Year 2019.